common symptoms of gastroesophageal reflux disease, such as heartburn, chest pain, are very well understood, and the approach to these patients tends to be fairly well applied. In recent years, however, atypical symptoms such as hoarseness, chronic cough, worsening asthma, a globus sensation in the throat, and others have sort of been brought to the forefront. And it's now been well recognized that in order to treat these patients appropriately, a different approach should be used. These patients have a variation of gastroesophageal reflux disease that manifests with symptoms up here in the throat. This manifestation is termed LPR, or laryngopharyngeal reflux. And in putting together a comprehensive heartburn treatment center program, it's important to involve the otolaryngologist in the evaluation of these patients, because the evaluation is different and the treatment is different. Dr. Benny Jarvis, an otolaryngologist here in Rocky Mount, North Carolina, will discuss the basics of LPR and how these patients are best approached.
I'm Dr. Benny Jarvis. I'm an otolaryngologist here in Rocky Mount, North Carolina with Carolina Otolaryngology Consultants. I've been involved with the Rocky Mountain Heartburn Treatment Center really since its inception, and I'm here today to talk to you about two things. One, the clinical syndrome of laryngopharyngeal reflux, and two, the role of the otolaryngologist in the Heartburn Treatment Center. Now, we're talking about laryngopharyngeal reflux, commonly known as LPR. For those of you who are not otolaryngologists, this is the clinical syndrome of pharyngeal and laryngeal symptoms related to acid reflux into the upper respiratory tract. This is important to talk about because this is different than regular, what you might call regular or the usual syndrome of gastroesophageal reflux, and it is very common. So if you think about extraesophageal reflux, it's involved in 75% of asthma, 20% of chronic cough, and 78% of these patients display chronic hoarseness. So it's a very common problem in ENT practice. It's different than GERD. LPR is different than GERD because only 43% of our patients present with heartburn, regurgitation, or dysphagia. Only 20% will display endoscopic esophagitis. You know, for years, as an otolaryngologist, we've been deciding people probably have reflux, sending them to the gastroenterologist, and the gastroenterologist does an upper GI endoscopy and says, you don't have reflux, there's no esophagitis. Well, in fact, most of these patients are not going to have esophagitis because instead of having large amounts of reflux in one event, they are having multiple small refluxes up into the laryngopharyngeal area, and so they'll end up with different symptoms. And more importantly, they require more aggressive treatment because, as I tell my patients, it takes a lot of acid to give you problems in the esophagus because that mucosa is relatively protected against acid. It's supposed to see a little bit of acid, but it takes only a small drop of acid to cause problems here in the throat because that is respiratory mucosa and it's much more sensitive. Now, what are the symptoms of LPR? Sometimes we'll see nocturnal cough or choking. Again, 20% of chronic cough has a reflux element. Globus sensation is very common. You know, I've got something stuck in my throat. I have a glob, I have mucus. You know, people describe it many different ways. Frequent throat clearing. Morning sore throat is pathognomonic. Laryngospasm is what we'll sometimes see. Halitosis can be caused by LPR, hypersalivation, hoarseness and dysphonia, and even chronic hiccups. As you look at the illustration on the screen, you'll see the larynx and the esophagus are obviously quite closely related. The esophageal inlet abuts the posterior larynx, what we would call the arytenoid for those of you who are not otolaryngologists. That is the area where, when you are diagnosing on physical exam, that you will frequently see problems. Sometimes we'll see redness. Sometimes the area will just be sort of humpy and swollen. You sometimes will see polypoid changes of the vocal cords themselves. But actually, many of these patients will have a great history, but their larynx will look fairly normal despite the fact that they're sitting there in your office you know, clearing their throat constantly. When I have a patient that I suspect is suffering from laryngopharyngeal reflux. Generally, I don't start with a pH probe study. What I generally do is start with a trial of a proton pump inhibitor. I bump them up to twice a day, first thing in the morning on an empty stomach and about an hour before dinner. Generally, if you do twice a day proton pump inhibitors, that gives you, as opposed to 80% acid suppression, gives you about 90% acid suppression. After 6 weeks of that, if I still am suspicious that it's LPR but we're not getting anywhere, that is the patient in whom I would do a pH probe study. You cannot send them to the gastroenterologist for the pH probe study because a traditional pH probe study is not going to tell you if LPR is present. It's better for the otolaryngologist to place the probe by himself or herself. It's easily done in the office. Generally, we place the probe in the office, the nurse reviews the patient instructions, and then the patient returns the next day to the heartburn treatment center. It's removed by the heartburn treatment center nurse, and she does all the computer analysis, sends it to me, and then I read the study. Now, when we're placing the probe, we use a special probe that has a dual channel pH probe, and I like to use a probe that has a mark here. If you don't have a mark pre-made on the probe, you take just a black magic marker about 1 centimeter above the upper probe. I numb up both sides of the nose. I take the left, usually the left nearest because most people are right-handed. I run this down all the way into the stomach, and I just monitor the pH as we go down to tell we're in the stomach. Once the probe is in the stomach, I take the flexible fiber optic laryngoscope through the right nares, get where I can see the larynx well, then have the nurse slowly pull back the catheter until I can see the black mark. When I see the black mark, then I push it back down until the black mark is just not visible anymore. And that will put this upper probe at the upper esophageal sphincter. Now, it's pretty simple. It usually ends up being between 34 and 36 centimeters, no matter if the patient's really tall or really short. The problems that I've had have generally been in people who have a very strong gag reflex. I usually just, really numb them up with hurricane spray. Sometimes I will also spray xylocaine phenylephrine spray back into the nasopharynx in addition to using xylocaine phenylephrine spray on a cotton pledget. The other problems I've had, sometimes people with big cervical osteophytes, the probe will want to curl up and go into the mouth. In those cases, I found it's helpful to put the flexible laryngoscope in first, run the probe down under direct visualization. Occasionally, I've even had to use a bayonet forceps to pass the probe down past that cervical osteophyte down into the esophagus. I send them home and tell them to try and go about their normal activities. Make sure if they know some foods or activities that tend to cause symptoms for them, I ask them to go ahead and do those things. Most patients stop gagging after the initial placement. They still feel the discomfort. If they're very sensitive, they'll complain about it all night. I've occasionally had patients that pulled it out early, but generally they tolerate it well, much better than they think they're going to. The next day, they come to the heartburn treatment center and the nurse takes the probe out. She sends the results over to my office. We read it, and it's very simple. It's similar to stuff we do every day in our office. When I read the LPR study, I'm really not looking at the Demeester score or the overall total of refluxes into the lower probe. I'm looking entirely at refluxes into the upper probe. And 3 to 5 refluxes into the upper probe constitutes a positive study. They are not necessarily going to be correlated with the symptoms. In fact, really other than the meal times, we don't look at the symptom diary very much because frequently we don't see correlation with the symptoms because most of our patients do not have typical heartburn symptoms that they can relate. They have more chronic all-day symptoms of hoarseness, throat clearing, and globus sensation. If the study is positive, I offer the patient a trial of further PPIs. We talk again about lifestyle modification as we have talked about before. And if they are not doing well, then we consider sending them to the general surgeon. Nationwide, Nissen surgery for LPR patients, the success rate is a little lower than for classic gastroesophageal reflux patients, normally about 80%. The difficulty clearly is that many of these patients with global sensation and hoarseness, their symptoms are from a multifactorial etiology, and even if you're eliminating the reflux, some of these people are still going to have symptoms. But the vast majority of the patients here in Rocky Mount that have had Nissen surgery for reflux have done well. Thank you for listening to me today. I hope this was helpful. In conclusion, I'd just like to emphasize that LPR is common, LPR is different, and needs to be treated differently and recognized in a different way. And in order to have a truly innovative and comprehensive heartburn treatment center in your community, you really need to include the otolaryngologist and the otolaryngologist patients.
As part of a comprehensive GERD disease management program, you can see how it's essential to identify these LPR patients. The key points is that the disease is very common and the evaluation and even treatments can differ from the typical GERD patient. These patients are treated effectively with medicine, and many are treated very effectively with anti-reflux surgery. The foundational concept, however, is that these patients are out there, they're all over the place, and once it's recognized that they could have GERD or LPR as the cause of their symptoms, the Heartburn Center provides an access point. And if they're provided access and then a liberal utilization of the appropriate and proper pH study, not a pH capsule placed low in the esophagus, but testing at the site of the symptoms using the catheter-based pH technique described, will allow accurate diagnosis, or at least as accurate as possible, and then proper treatment that follows. So the otolaryngologist is an important participant in the Heartburn Center, as well as the entire team recognizing these foundational principles of LPR.